It's been no secret that my own running career has had its fair share of ups and downs related to injury. Like so many runners, there have been times when I've found myself spinning my tires through the same roundabout of issues, going in circles with band-aid fixes that offer temporary relief but fail to break the injury cycle. That cycle can feel like a game of whack-a-mole, with one nagging pain going away only to be replaced by several different issues elsewhere. For the injured runner, the path to lasting health and getting back to the pain-free running that we're all seeking begins with the right diagnosis. Yet while that may sound obvious, the reality of getting there can often feel far from straightforward. In this episode, we explore why so many runners treat the same injury over and over without lasting success, and how shifting the focus to accurate diagnosis can break that cycle. I'll be taking you inside my own personal journey navigating injuries that seemingly wouldn't go away, and how the right assessment and the help of great care providers help get me back on track. Here to help break it all down is Doctor of Chiropractic, Bryan, one of North America's leading practitioners when it comes to helping runners get healthy, stay healthy, and keep running strong. Bryan helps us unpack some of the common myths about dealing with injury and pain, and lays out a path for runners to take on a more active role in their long-term resilience by working alongside their care providers to create lasting results. So whether you've been stuck in the not-so-merry-go-round of injuries or are looking to protect against setbacks on the road ahead, then this is the episode for you. Bryan, welcome to the Shakeout Podcast.
Hey, thanks for having me. I'm super excited to be here, and it's great to officially be known as one of North America's top providers. So that's pretty sweet.
If it's said on the Shakeout Podcast, then it makes it official. So I am glad to give you that distinction. And excited to share a little bit of my story. That's something that I don't get the opportunity to do a whole lot, is share a little bit of my story. And you've been a big part of my personal journey through injury and onto the road to recovery and healthy training. And we're going to dive into all of that later in the show. But first, I want to let you have the opportunity to share a little bit about yourself, your experience with the sport as a runner yourself, and now as a chiropractor and somebody helping runners run at their best and stay healthy.
Yeah. So my running journey probably started a lot like your running journey. I was 10 years old when my dad ran the 100th Boston Marathon in 1996. And I don't know, something happened in my brain where I was like, all right, that's it. That's what I'm going to do. And even prior to that, my parents were very active in getting us just like trying lots of things. So we would do like track meets and fun runs and 5Ks, even from like the age of probably like 6 or 8 or 10. Not like the Sha'Carri Richardson, like officially competing at USA's when she was 8 or something like that. It was just like, hey, we went to a track and ran a bunch of other little kids. But that really sparked what can only be described as an obsession through high school. And then I ran in college. And I think like every college runner, I just, had big dreams and was convinced it was possible to be a professional runner. But coming from D3, I knew it was going to be like about a 1 in a bajillion. And it didn't work out. I never became a professional runner. But after college, I switched to racing triathlon. Because at the time I was like, hey, the pros, run 10K off the bike in 33, 32. I can do that. Now I just need to be able to swim and bike. So I moved to California, spent every dime I had on races and travel and bikes, and tried to make a go at being a professional triathlete. Somewhere along the line, just was like, I think I'm actually going to need a career here at some point. And that's how I ended up becoming a chiropractor. I had 2 really great chiropractors who had kept me, on the road to racing. And I had experienced, every injury under the sun. And until I had found these 2 chiropractors, I just was not getting the results I wanted. And so I became a chiropractor because those are the people who helped me. So yeah, that's a little bit about me.
That path to rehabilitation is something that I want to steer us deeper into. And as we talked about in the intro, my own path to getting back on my feet after months, arguably years of dealing with injury is going to be one of the lenses that we look at that through. Now, for some context to our listeners, I've struggled with, again, like you and like many athletes who have reached a high level in the sport, pretty much every injury under the sun. But the past year in particular was a whole basket of different injuries. And I had gotten to the point where I just wasn't seeing results. I would get relief for a couple of days, but inevitably I would find my way back into the same patterns of pain and discomfort and the inability to run the way that I had ran when I was at my best. And I think any injury prone runner or anyone who's dealt with injuries will empathize with that, that when something is off, it just quickly takes the joy out of the sport. It takes the sense of naturalness out of the sport. And when I started working with you, it was very clear that there was going to be a path forward that wasn't going to be a quick fix, but at the same time, going to give me the opportunity to take back a little bit of agency for my own healing journey to make sure that when I came out the other side of this injury, I wasn't going to be starting back where I'd begun. So my first question for you is, as a care provider, when a runner comes to you with the type of injury cycle that I've just described, where do you begin? Because it can be so overwhelming from the perspective of the runner when everything hurts and nothing is going the way they want.
Yeah, it's a really great question. And I think it probably changes depending on who I'm talking to and depending on what they're presenting with. What you had just said about restoring agency and autonomy, I think is one of the most critical, if not the most critical thing that I can do for a patient and for an athlete. And the way you do that is not actually by getting rid of their pain. It's by helping them understand what's going on, what's not going on, right? What did they bring to the table as far as things other healthcare providers have said to them, diagnoses they may have received, imaging, preconceived notions, right? I think one of the best things about runners is the worst thing is that we like to create community, and that's wonderful. And in that community, we all just tend to share horror stories and not success stories, right? Like, um, you know, Instagram, Facebook, Reddit, like you can find a whole plethora of all the bad things that have happened to runners. It's a lot harder to find success stories. And I think that is really difficult. And I think most of my runner athletes come to the table with that baggage to some extent, right? Whatever that may be. And so I think, if I have a new patient in front of me and I think the baggage is so great that I don't think we're going to get anywhere unless we start to unpack that right away. That's usually the direction I actually go, is understanding what is this person bringing to the table that mentally and emotionally is going to prevent success ultimately. And so I have had athletes who the first 60, 75 minutes, our first visit is usually 60 minutes. Sometimes it goes longer. It's just like unpacking stuff. We don't even get into the nitty gritty. It's just like kind of giving people the opportunity to just like dump it all out there and say, this is all the bad stuff that I've experienced or felt. And here's what I feel like is going on inside my body. This is my lived experience in spite of all those things. And maybe so much of it, if we can just kind of clear the table emotionally, that's sometimes the best place to start.
That clearing the table is something that I'd love to spend a bit of time on because it hits at what I think the experience I went through many times with injuries and many other runners go through is it's very difficult to separate the specific injury itself, whether that be a hamstring tear or a bad knee or plantar fasciitis, from the general feeling of, I don't want to use the word hopelessness because it's not always that severe, but that kind of pallor that comes over you when you know what the root cause is or what the root issue is in the way that it feels and it hurts when you run, but it has this way of permeating out into every other aspect of your sport. And maybe you're not running, so you're not seeing that running community that's important to you, or you're working harder than ever and feeling like you're going backwards because this injury is taking up all of this extra energy. And that, I think, is the thing that I struggled the most with personally, was how do I clear all of this extra baggage out of the way so that I can hit at the root cause and not get pulled in all these different directions. Take us a bit more inside how you go about clearing the table, so to speak, so that athletes can really begin the work of actually healing the injury.
The first and foremost thing for me is helping my people understand, are you injured or are you in pain? And there is a difference, right? So for me, an injury is like something that has, for lack of a better term, like catastrophic tissue failure, and it has consequences. right? A bone stress injury is not catastrophic tissue failure, but it is tissue failure, and it is tissue failure that cannot be ignored, right? There is not a place on earth where I'm going to tell someone who I suspect has a bone injury that they're good to run. And I am not the type of provider who just tells people to stop running willy-nilly because they're in pain. In fact, most of the time I'm encouraging people to understand, hey, you're in pain, but you're not injured. So we're going to train through this, right? You need to understand that your training has a cost, but that cost may not be catastrophic, right? And so I think first and foremost, is my patient injured, or are they in pain and experiencing some spectrum of what we call a pain syndrome, which just describes a collection of behaviors and kind of qualities of pain, and how your body interacts with the pain, how your pain responds to different stressors, and creating a category of where your pain may fit in a very, it's not like neat and clean like a Christmas gift, but it definitely has functional delineations where we can say, okay, it does this, this, and this, it's probably hanging out in this category or type of pain. If it does this, this, and this, it's hanging out over in this category and this type of pain. And just that alone, being able to say to someone, hey, you're not injured, you're not broken here, you're in pain, and your pain is to some extent really useful and informative for me, the clinician, because I speak the language of your pain. That's my job, right? My job is to say, I know what your pain is saying, and I know why it's saying it. You feel like you know what your pain is saying. However, your experience of pain is influenced by all that stuff we already talked about, right? What is the baggage that you bring into the treatment room that is influencing your experience? Every pain that we experience to some extent is going to come with what we call a psychosocial or a psychosocial emotional factor, in which case, like, pain is not as clean as we want it to be, in the sense that it's like, I tear my Achilles, I have pain, I do the surgery, the rehab, and I'm good to go, right? That's really clean, and that's just not how pain behaves, right? You had said pain is changing your life, it's changing your behavior, it's taking you out of community. And once it does that, it is no longer the same thing that it was if you started with, we keep speaking of like big injuries, tears and things like that. But like most of the time it's not that, especially in the endurance running community. Like the number of like true strains and tears I've treated is less than 5. It's very rare in my experience.
I want to take a moment and maybe delve a bit deeper into that distinction between pain and actual injury.
Yeah.
What risks do we run when we start fixating on the pain itself, maybe at the expense of the actual injury at the root of that pain?
And I say what I can say for the user, right? The user experience of pain is that we have been educated that like all pain has to come from something that's broken or damaged or injured, right? Like even, an Advil commercial, right? They have like Advil low back pain meds now. They're the same meds as regular Advil. There's nothing different about it. It's marketing, right? But when you see the commercial, they're showing herniated discs and like bright nerve signals and all this stuff that is educating you in your brain that like something is terribly, terribly wrong there. Typically inflammatory. We love to blame inflammation on everything, right? Oh, it's inflamed. It's inflamed. Everybody comes in and they're like, it's inflamed. And I'm like, is it swollen? And they're like, no, but it feels inflamed. And this sounds like me being an asshole, but it's like, can you feel the difference between inflammatory pain and non-inflammatory pain? And the answer is maybe, no, yes, it really depends. But I think most of the time we feel pain and then we have the cognition of, okay, what's going on? And then it goes, well, I had that, sprained ankle 30 years ago and that was inflamed, and this kind of feels like that. So it must be inflammation, right? And so we're just using our lived experience to help inform our pain experience. The problem is that pain in your brain, you experiencing it, is an unreliable reporter to you. It's a fairly reliable reporter to me because I know what questions to ask. In your brain, your pain doesn't say, hey, let's think about this, and I'm going to provoke 20 different questions that you in pain, I want you to consider. No, it just happens, right? And so the fixation that we have that there must be something wrong is actually probably in the long term making your pain worse, right? If you think about how pain is processed in the brain, we have been taught that it's like, okay, I stubbed my big toe and it goes up this one little line to this one little spot here in the sensory cortex, and that's it. And it's like, actually, what it looks like is it hits your upper brainstem and it explodes into many, many different areas of your brain, right? We have our sensory cortex, which is, primarily on the cortex on the opposite side of the body. So if I have left hand pain, it's going to be on the right side of my brain. But it doesn't just go to that one spot. It has to be relayed and filtered through all of these different areas of the brain. And so much of that experience that then comes through to you is due to what you've been told, experiences you've had, fears, doubts, beliefs. And that is not to say that this is psychosomatic and you're making it up. It is to create a link between our emotional experience of pain and our physical pain signal that is being generated from a peripheral site. And so the more we fixate on this, the worse it's going to get. One of my favorite questions to ask is, how often in the day are you thinking about your pain? And if someone says to me, they're like, I don't know, 5% of the day, and the rest of their history kind of mirrors that, I'm like, oh, okay, this is maybe a little less emotionally involved. But with most of my runners, especially if they've been dealing with a persistent problem, they say, I think about it constantly. And then my brain is like, all right, now I need to know what you're thinking about. And that's when I start asking questions.
That seems like a great opportunity to jump back into my own case study, because what you're describing really relates to the back injury that was the context in which we started working together. It was something that had really taken over my life. There wasn't really an hour that would go by in the day where I wasn't thinking about this back pain, but the pain in my back itself wasn't the entire issue. I just didn't have the right questions to ask myself in order to pull back the layers and find out what was going. And that gets to the idea of this hierarchy of needs and hierarchy of issues. A phrase that I've come back to is, you talk about touching where it hurts, but treating where it's needed. Can you unpack that a little bit for us, and why, in the context of my own back pain, that was the sensory experience I was having, but it wasn't as simple as, let's fix the place that it hurts on my back?
I think this also kind of goes back to the last question of differentiating between an injury and a pain, or a pain syndrome. And for lack of a better term, you know an injury when you see one, because it presents pretty catastrophically with, like, if we're talking about a true plantar fascia tear as the primary cause of the pain, everything sucks. Walking sucks. Sitting sucks. Walking on your toes sucks. Walking on your heels sucks. Like, everything sucks. There's no quality about it that's not bad, right? But most of the time, there are things that are not awful about it, right? There are things that you can do. There are things that are functional. So to get into this like hierarchy of pain, we've kind of already talked about the psychosocial one. And honestly, that's, for me, 75% of the time with a persistently injured, I hate that term, a runner who's experienced persistent pains is like, what are you bringing to this? And like, What do you need to see, feel, or experience to be able to say, I'm going to be okay? Like in the long run, I'm going to be okay. Because most of them say, I don't know if I'm ever going to be okay again. And I don't know if running is ever going to feel the same again. And that's a big problem, right? Like if you don't think you'll ever run pain-free again, you're not in a good emotional place. And so we have to just get you first and foremost to do something that says to you, I'm going to be okay. I don't know how long it's going to take, but I'm going to be okay. And clinically, I trust the person sitting in front of me to be my guide, right? So that would be the top of the pyramid. It's like, if you can't do that, it almost everything else probably doesn't matter, to be honest with you, right? And so you really have to get to a place where you feel confident that you're going to be okay. And that's a big part of my job, is to help you understand. And that's that, again, the agency, the autonomy. It does not come from taking the pain away. It comes from understanding your pain and almost having a relationship with your pain so that you can have a dialogue with it, right? You need to have the ability to talk to your pain, and whether that's you're talking to your pain here or you're talking to your pain through physical means and rehabilitation. So if we've established that the patient is in a place where they actually are going to be able to receive input, I mean physical input, not like, oh, I'm telling you what to do input. Like, is your brain in a place where it's going to allow me to like interact with it and show you that it can change? Or is it not? From there, it's difficult to say that there's like a stepwise hierarchy. But I think for me, I like to start with the home of pain, and that's the nervous system, right? And what I'm often asking myself is, does this person's brain feel like they are under threat, right? Is there a definitive brain-body connection where the brain is like, hey, we're in deep shit, or we're in shallow shit, or things aren't right, but we're okay kind of thing, right? We want to understand where they are on that spectrum and where is that threat coming from, right? And what are the most imminent threats to the nervous system, and where do they come from? For me, most frequently, most of my runners are going to come in with a lower extremity complaint. The first two places I'm going to directly look are the spine, the low back specifically, and the actual peripheral nerves that come out of the spine. And I'm going to say to myself, are these two things okay and don't need any attention, or do they need attention? Because the view that a lot of people come from is like, they want to start at Z because that's where they feel it, right? They feel it in their calf, right? And if you're a runner and you have calf pain, you go, I must have a strained calf, right? Well, if you have a strained calf, then you have a tear. It's a small tear, but it's a tear. If you have a tear, you have inflammation. If you have inflammation, you have pain. And therefore, you have a very stepwise process of how you're going to get over that strain. And it does not involve running, because if you have torn tissue, running will continue to tear the tissue, right? So in their brain, they're like, Bryan, you got to fix my calf. I have a calf strain. And I'm like, okay, first of all, you might. So if someone tells me they have a calf strain, I'm going to make sure they don't. Just because I don't think they do doesn't mean that I know their body better than them, right?
Yeah.
They might have had a calf strain. Most of the time, not. And so then for me, I say, all right, I need to develop evidence through an exam that shows me how it could go from their low back or their peripheral nerve to the calf. And you basically start checking boxes. Basically, the last thing I'm looking at is muscle and fascia. It's really far down my list. But it is the top of every person's list who comes in my office. It's always like, it's my plantar fascia, it's my piriformis, it's my psoas. Pick one body part in the lower extremity, and I've had someone come in and say, this is my only problem. And the number of times that's actually happened is like 0. It's just not how pain behaves.
So when we go back to that nervous system output, low spine, being the driving cause of the pain that manifests in other areas of the body. What's going on? What's leading to the dysfunction in the nervous system that's making it manifest in the fascia or in the muscle fiber itself?
Well, we don't actually know like with clarity or certainty at all to say that it is manifesting in the muscle fiber or the fascia, right? That is, for me, an experience, right? My experience is that it's in the fascia because I have foot pain, and every runner I know who's had foot pain had plantar fasciitis, or at least that's what they told. Right. And so my experience is that there's a problem in the fascia. When we don't actually know how much that contributes, even in a world where we have MRI evidence of a tear or swelling or really anything, right? Because your MRI is a photograph in time of you lying in a tube. That's it, which can be helpful if you were in a car accident and we want to know what's broken, right? If you are a functioning human, it is a very incomplete picture. I have a really good example of this, actually. I worked with a professional runner, I can't say who it was, and they had a torn plantar fascia on MRI. Definitive, torn plantar fascia, okay? And they had not run in like 8, 10, 12 weeks, something like that. It was a long time. They'd been in a boot. They had had shockwave. They had a PRP injection. They had a cortisone injection. They had acupuncture. They were getting deep tissue all the time, Graston all the time. They may not have called it Graston. Graston is a brand, much like Nike. We call it instrument assisted. Everyone likes to call it scraping now, and I hear that word and it's like nails on a chalkboard. I literally get the heebie-jeebies and I hate it. They had everything under the sun and they still could not run. They could not weight bear. They couldn't do a calf raise. They had pain. And for them, they were like, I have a torn plantar fascia. If it still hurts, it's still torn. And the reality is they actually might be right about the tear, that it's still there. The question is it consequential? Does it matter? Right? Does it matter that you have a torn plantar fascia? And everybody at this point might be going, of course it matters. But the reality that we are learning right now in healthcare is that you can tear shit and it doesn't have to hurt and it doesn't have to cause problems. It can happen slowly over time. The whole time your brain's like, yeah, we got this, we're aware, we're okay. And you are, right? You develop strategies around it. Maybe you don't even need to develop strategies around it. Your body's just like, we're good. Don't worry about it. So anyways, this professional runner is telling me all this. And I'm like, has anyone looked at your low back? Of the 30 providers you've seen, has anyone looked at your low back? Not a single person looked at her low back. And she's like, well, I don't have low back pain. And I was like, fair. And all of your sensory input to the brain has to go through your spine. And if someone didn't look at your spine, that's crazy to me. So we looked at her spine, gave her some very simple exercises, and lo and behold, her pain started to go away. In fact, she went for a run the next day, and I didn't even have to touch her. I didn't do anything. I told her what to do. They did it. They ran the next day. Now, granted, that did not fix the pain. It was a layer, right? And that's where this hierarchy comes in. It's like, if you don't understand all the different layers to your pain, and understand that there can be a hierarchy. There can even be like an order of operations, like PEMDAS. And I think that's algebra. I was a horrible math student. But PEMDAS is like, if you do this math equation outside this order, it will be incorrect because order of operations matters, right? It matters in mathematics and it matters in the body, not all the time, but sometimes. And so this person had to go through a bunch of rehab to do this, but part of her pain processing and part of her pain manifestation was absolutely coming through the spine. And that was because her spine was sensitized in some way to this pain process. Or the other way around, Their spine was just generally sensitive. And so pain coming through that kind of toll booth, so to speak, is not getting a clear transport to the brain where it can say, hey, I am just the influence of the pain from my foot. It's like, no, you got other stuff on the way up that if there's stuff going on there, it can influence it. And now that people are going to be like, well, what kind of stuff? And it's like, well, we don't always know, right? We're very comfortable with the idea of a disc herniation in the low back causing pain all the way down to the foot. Nobody questions that, right? Why? Because it's easy to see and explain and understand. It's like, cool, MRI, disc herniation. Cool, pressing on this nerve. Cool, that nerve goes to the foot. Are you having foot pain? The patient's like, yes. And then we go, okay, it's coming from your low back. That's clean. It's never that clean. It's very rarely that clean. But the influence is similar.
So how do we change those inputs then that are going up the chain? So in this case, for instance, they're having pain. The input seemingly is their foot pain, and it's going up through the low back. They don't really recognize that it's happening at the low back. How do we go about tweaking the input to send a different message to the brain and tell them, actually, the pain isn't what you think it is, or it's not as bad as you think it is?
Yeah. So the worst answer in all of healthcare is it depends. And it depends on why the person is having some sort of spine influence into the pain. The easiest one to explain is one that we would call mechanical sensitivity. There are clinicians who would call it a derangement syndrome or a derangement presentation. So there is a system of categorizing and assessing pain called the McKenzie method. And the McKenzie method relies on something called mechanical diagnosis. Okay. Very easily and simplified down is that McKenzie is trying to understand what role movement can play on different areas of the body. For example, I have patients who come in all the time, they have low back pain, or they don't have low back pain. Maybe they have extremity pain, they have leg pain, and they say, when I touch my toes, my pain happens. So for a person who thinks in this mechanical sensitivity way may say, does lumbar flexion have an influence in their pain process? Well, it might, because they just told you when they bend forward into flexion, they have pain. That's their pain. Boom, my pain turned on. Okay. If there is a mechanical input that makes your pain worse, is there a mechanical input that will make it better? So very frequently, these people who don't like to bend forward, we bend them backwards. We put them into the biggest extension that they can manage, and you do it a ton. People will be like 5 or 10, and I'm like, no, like 100 or 200 times a day. It's a stupid number. I'm aware of this. But when you have mechanical sensitivity, it's like paying off credit card debt. And the longer you've had mechanical sensitivity, it can sometimes be paid off really quick, and sometimes it just takes a while. And so it behooves one that if you're trying to pay off credit card debt, you want to do as much input as possible, right? If you have actual credit card debt, which I have had, I find $10 on the street and I'm running straight to the ATM to put it into my bank account so then I can put it into my credit card, because compounding interest sucks, and that compounding interest can happen in the body in kind of a similar way. So to answer the question very simply, it's like, okay, is there an input that makes your pain worse? What happens if we do the opposite? Does your body have what we call directional preference? And that's, okay, if I hate leaning forward, do I like leaning backwards? The answer is yes, maybe, no, sometimes it depends. Everybody's different. So we don't have like a panacea of saying everybody bends their spine backwards if they have mechanical spine pain. It just doesn't work that way. But a lot of people do end up doing press ups. And so there's a joke in our clinical stratosphere among our patients, because they all know each other, because it's run groups and rowers and different groups of people who end up finding us, and they all joke. They'll be like, did you go see, someone at Forward? And they're like, yeah. And they're like, did they make you do press ups? it's just kind of a joke because so frequently the spine is involved.
And that was very much my experience. The first exercise I was prescribed was, I think, something like 150 to 200 back bends. The cue I was given was push back off the ground as if you're trying to break your back backwards, because I had been presenting all of these symptoms of low back pain. When I remember starting it, it was uncomfortable. It was hurting in the moment to do these exercises. What is the value that we're getting out of pushing through that pain and that discomfort? Because to some minds, that will seem counterintuitive of, okay, this area hurts. Let's do an exercise that is going to provide more discomfort in the moment.
So I want to be really clear right now. If you're going to listen to this and be like, shit, I need to try these back bends, please don't. As a routine, we do not give exercise recommendations to people who are not going to be our patients, because the wrong exercise can make you worse. Period, end. Right? So, like, this is not medical advice. This is trying to help people understand about categories of pain and hierarchies of pain, and understanding that pain is multi-leveled, so that when they go to a provider, they have a little bit of something to be like, is my provider asking all the right questions, looking at me as a whole person, and going to treat me holistically and not just touch me where it hurts, right? Are they going to do a good assessment and understand the different players in the pain, or are they just scraping my calf for 45 minutes twice a week for 10 weeks and hoping for the best, right? So to answer your question, sorry, what is happening when we do something like extension? Well, we don't know all the answers to that question. And I want to be clear that I am an evidence-informed provider, but I do not know everything about neurology and functional neurology. My expertise comes in the form of understanding overarching principles versus deep dives on like specific neurologic processes that are happening when we bend backwards versus bending forward. But the simple answer is that in your spine or any joint or any series of like movement segments, it doesn't matter if it's your elbow, your shoulder, your low back, your hip, whatever, you have a whole collection of different sensory apparatus that are there to tell you and your body about what it's doing and keep track of those stressors and those inputs, right? This is the example I give to everyone. If you are not watching this, what I'm doing is I'm bending my index finger as far as it can towards my palm, and this is called flexion. And if I came to your job every single day and I held your finger in this position for 9 hours a day, every day, is it going to start to hurt? Well, I don't have a crystal ball, so I don't know. But most likely, at some point, you are going to get feedback from this system that you're not a big fan of this collective repetitive stress, right? And so the more frequently I do it, the more sensitive you may become, which means on day 1, it didn't hurt at all. It started to hurt on day 30, but only after 9 hours. And then on day 60, it started to hurt after 1 hour. And on day 90, now it hurts immediately. And on day 200, it hurts all the time, right? That is a spectrum of sensitivity that has been gathering over time, despite the fact that the stress doesn't change, right? And we would look at that and say, well, this is inherently a normal thing to do to a joint, but the way we've done it is so highly repetitive that it has become stressful. And that's a good thing. Your brain is doing its job. It's protecting you, right? So now you have a system that is mechanically sensitive to motion or lack of motion, right? People complain about posture all the time. It's not the position. The position is inherently benign. It's the fact that you do it 15 hours a day, right? You could have great posture and be totally upright and extended, and that would still hurt, right? So now I have a system of, fibers and structures that are now mechanically sensitized to position or movement, etc. And so when it comes to the spine, typically what we have is a series of other breadcrumbs that have been affected, right? And so these folks often have like some type of nerve irritation on a leg, and so we can check for that. They have different ranges of motion that hurt and different range of motion that don't. And so what we would do is say, okay, you've been stuck in flexion. Let's try extension. So we extend, and now we go back to those breadcrumbs and say, did you neurologically change in real time? Did your range of motion improve? Did your pain with range of motion improve? Did your neural outputs change? Hell, like, did you test weak on a muscle test and now you test totally strong? There's all these different things that can happen. And we say, if all of that stuff got better, or some of it got better, but your back hurts, that's okay. Because we did an exam and we said, okay, the likelihood that anything really bad is happening in your low back is very minimal. So we've ruled out all the scary stuff. And we've said, okay, you are a mechanical pain patient. We are safe to push your spine in a normal range of motion and make it do its job. And sometimes, because that system is highly irritated, it's not going to feel good. But you have your data set to say, this is safe, number one. And number two, are my outputs from my brain changing because of it? Right? So we do input into the brain. If the output is getting better, we're good. Right? We can push through that knowing that the pain they are experiencing is very likely not from tissue damage or trauma or anything like that. It's due to a system that doesn't want to move, but you can't avoid motion. It's the most crazy thing when you think about it, especially around the spine. People all the time will say, don't bend backwards. That's dangerous. And I'm like, what makes it dangerous? They're like, well, it typically hurts. Well, did you do an exam? Do you know why it hurts? First of all, we don't always know why, right? You can have pain of unknown origin. And I've had surgeons say to me, don't bend my patient backwards. And this is not to discredit a surgeon, but at that point, I had already been bending them backwards for a month and they were doing better, but they had the surgical consult on the schedule. And so the surgeon's like, bending backwards is dangerous. And I'm like, yet they've improved 60, 70, 80%, whatever, doing that. So is it dangerous or is it misunderstood? And to kind of give some credibility to your question is like, does it hurt? And is that hurt due to harm or is that hurt due to a system of pain? Right? If it's due to harm, don't do it. If it's due to a system of pain, understand what is the effect, right? What happens when we do it? Do things get better or do things get worse? So that's the key, is what is your brain doing with this data? And if the only bad thing is that you feel worse, but everything else is getting better, we're good to go. Typically. And that's, again, this is not medical advice. This is storytelling, for lack of a better term.
That idea of if nothing is getting worse, we continue down that path. It brings to mind the idea of compensation injuries. Again, very prevalent within running. The example that you used of pressing the finger over and over again, and then eventually over time, it starts becoming a point of sensitivity, seems to strike home at the experience of many runners where they start running without any pain or discomfort, but because of the repetitive nature of the movement, over time, those inefficiencies or maybe small weaknesses manifest into these bigger patterns and compensation patterns. And that was certainly the case in my own career. Anybody who's ever seen me run will know that I run with a bit of a, I guess, telltale limp. It's kind of my signature move, so to speak. And for years and years, I was able to get by. I mean, I made it all the way to an Olympic final with this very apparent limp to one side of my stride. I wonder, to what extent is it okay for our body to allow itself to compensate and to find different paths around the pain or around the dysfunction, to play with the cards that we've been dealt, so to speak, versus trying to rewire our brain towards something more optimal?
Amazing question. To some extent, it may depend on who you ask. What I can tell you from my knowledge of the research is that biomechanics, that's what you're explaining. It's like how your body moves through space and interacts with things like gravity. Biomechanics are a factor when it comes to pain and injury, but they are not the most important factor necessarily. Okay. So you're a great example, right? You've had a physical reason to develop the gait you've developed, right? And some people would call that a compensation, and they would mean it in a not so nice way. They would say, ugh, look at that compensation pattern. Gross. I see compensation as like, how remarkable is your brain that it figured out a workaround that was still good enough to get you to the Olympic final? Like, obviously, it's not inherently an extraordinary deal breaker for your running, right? And so if people are out there trying to have perfect form, my question is like, does it need to be perfect? And the answer is no, right? There are people out there who have truly magnificent gait that is beautiful to watch and feels like a miracle when you watch it in full time and in halftime. You know, the person that I, am fanboying over their gait the most is Nikki Hiltz. Their gait is, I don't want to say perfect. There's no such thing, but it is magnificent. The lack of energy wasted in their body when their foot hits the ground is just remarkable. And they're kicking ass right now. But there are people who have less perfect form who maybe have beaten them in a race, right? And so it's not necessarily about perfection. It's how do you manage stress? The number one reason that runners get injured, and this is in the science, this is very clear, is load management issues. It is user error, and it's because you did too much too soon on a body that wasn't ready to handle it. And that could be an actual tissue trauma, or it could be in this world of pain syndromes over here, where we have a collection of different things that may be going wrong. Regardless, you've exceeded the capacity, and the system has just said, hey, we're done. Like, this is too much. My job as your nervous system is to tell you when you're doing too much. And guess what? You're doing too much. Here's your pain, right? Listen to me, or I'm just going to keep telling you, because that's the only way the body can communicate. So I think it depends on the person of how deep we decide to go into changing the way people move. I think it depends on the sport. I think it depends on the season of the sport, right? If I'm going to say, you know what, I think I want to manipulate your biomechanics a little bit here, and you come to me 6 weeks out, 6 months out, a year out from an Olympics, I'm not touching that. I'm like, nope, we do not need to change anything right now. Let's bolster up the system you have. Let's really understand what inputs we need to do to have you be the most successful, both neurologically, but also like from your motor output standpoint, and go from there. I've had some recent athletes who I've done a little bit deeper dive onto changing the way they move through space, and they're coming off of some pretty big stuff, right? Their body kind of needed a hard reset. And so we said, okay, are there things here that are getting in the way of you being successful from a function standpoint? And if we work with those things, will it make you a more efficient athlete? If the answer is yes, then I typically will start to work those things. If the answer is you're in pain and getting you out of pain is not going to necessarily change your mechanical function, but we don't need to, then typically I'll say, let's get you out of pain and see where you're at, and then recheck things. So it's very patient dependent.
How do you differentiate between a compensation or, let's say, something in their stride or their gait that's off because of injury versus a compensation pattern that's productive? For instance, I always have had this limp, but when the back pain started, it pronounced everything that much more, and other things started going out of whack above and beyond what was my normal. And so I was never on track to have Nikki Hiltz-esque form and run perfectly symmetrically, but from my norm of that pre-existing limp and the visible differences in my gait compared to the textbook running form, I had regressed even that much more. How do you go about differentiating that from simply a compensation pattern that's working?
That's a good question. I think with your case, it's easiest to kind of speak to what we were dealing with you was that there was a significant regression in the pattern. It was like, I've always had this thing, but holy cow, like it just feels and looks so much worse. And so the question is A, where did that come from, right? What's the root cause? B, can we do anything about it? And knowing what you can influence and what you can't, or knowing how quickly you can influence things and how quickly you can't. And then, the patient need. And I think a lot of it depends also on like, what's the person's goals, right? Am I treating an Olympian or am I treating someone who's running their first 5K? Like those are different people with different needs and different demands placed on their body. And they have different goals, right? And so you have to ask yourself, like, what do I need to do clinically to help this person meet their goals? If you're a professional athlete who's been on this, I call it the wave, where you've just had injury after injury after injury, or pain after pain after pain, and you are just really struggling, that's a very different case than someone who comes to me, professional runner or otherwise. They're like, hey, I've been really healthy and I got this little thing that popped up. Cool, let's watch you run. Don't see anything that's really weird there. Okay. Or in your case, we watch you run and we're like, does this fit what you're telling me, right? Is this the problem? Or is this something your brain has dealt with and is relatively okay with? And even then, it's like, what do we need to do to change motor output? And motor output is how we move through space, right? Some people call it muscle memory, but motor output behaves in a pattern. And for someone who's had the same gait, whatever we want to call it, variability for 10 years, that is a very well-developed neurologic pattern that may take a significant amount of time and effort to change and may not lead us to the goals that you want to achieve.
That idea of tailoring the treatment to the goals is an important one. And I think what we've established over the course of this discussion is regardless of the level that an athlete or runner is coming to you at, if they have pain, the goal is to ultimately break free of that pain cycle and get back to a place where running is the sensation that they want it to be, the positive thing that it probably was for them at some point on their running journey. And that gets into the idea of making sure we get the right diagnosis. You talk about a term called the differential diagnosis. I wonder if you could explain that to us, and from a differential diagnosis, the path forward that an athlete and their care provider are walking together, what role the athlete has to take in terms of accountability for the long-term outcome of getting back to that optimized state of running.
Okay, differential diagnosis. Really unsexy term, but really, really, really important that you as a patient understand what a differential diagnosis is. Okay, differential diagnosis means you come to me, you have foot pain. You tell me it's plantar fasciitis. Why? Because that's what it feels like, right? And that is not to like mock or belittle people's experience. It's more that like plantar fasciitis is an umbrella term for foot pain, and we really shouldn't use it as freely as we do, right? Because clinical diagnoses matter, because when you have the diagnosis, that tells you what to do, right? So if you come to me with foot pain, I say to myself, okay, what are the different, hence the term differential, diagnoses that could be involved here with my patient's pain? Could it be the fascia? Sure could. Could it be a tendon? Yep. Could it be an inflamed tendon? Yep. Could it be a chronic tendon problem? Sure. Could it be a bone? Yep. Could it be a ligament issue? Yep. Could it be a nerve issue? Yes. Could it be a joint issue? Yes. Could it be coming from the low back? Yes. Could it be coming from the cervical spine? Yes. That's 9 for people who aren't watching. 9 different things that are on my list to say, who is playing in this sandbox? And the answer is it could be 1, it could be 2, or it could be 9. Could be all of them, right? And that, if there is a if there is a thesis statement to this podcast, I guess today, if you go to a provider and they say, it's this, you should ask, what else could it be? And why isn't it that? If they don't come up with a list of 10 different things that it could be and explain to you specifically why it cannot be those things, they're probably not looking, and they should. So a differential diagnosis is who's involved here? What are my injuries and who are my pain players? You want to make sure you get those injuries right, because if you send someone out to run on a broken tibia or a stress fracture in the tibia or the talus and it breaks all the way through, now you got a surgical case in some instances, and that is a bad thing. Right?
Yeah.
You want to avoid that kind of stuff at all costs. And so that's my primary job, is to say, is there catastrophic tissue failure here that I need to make sure I don't miss? If those are all taken care of, now my differential diagnosis is just who is playing in the pain sandbox together and who's the most important to treat first. And I do think that frequently we try and treat too many things all at the same time, and it just becomes this gobbledygook of, I have no idea why you're getting better or you're getting worse. So if you're getting a, exercise sheet of 30 different exercises, they're doing 30 different things for very different reasons. And if that's where you're at 20 weeks into care and you've built that over 20 weeks, that's one thing. But if you're week 1, they're like, here, go do these 10 exercises, come back in a week. Like, I don't want to say that's bad, but it removes the ability to go through my differential diagnosis and know what's going on. Because if you have the right diagnosis, there typically is, I don't want to say a standardized treatment, but there's really good research to support specific treatment kind of circles or areas where if you throw a dart at it and you hit it, you're going to at least be mild to moderately successful. And you're going to be more educated on what's happening to your patient. Whereas if 10 different things are happening and you get worse, now you have no idea why. And now your differential actually is now bigger.
I like that analogy of the dart versus maybe contrasted with a shotgun approach of, well, it could be all of these things, so we're going to try and treat all of them all at once. And that can be overwhelming for a patient. And I think that's where I've had discouragement, and almost any other runner I've talked with has had discouragement in the vicious cycle of injury that they might find themselves in. Is they get given a quick answer by a care provider, this is what's wrong with you, do this and this and this and this and this, and it'll go away. And then they take those exercises and they go, and maybe they're really consistent for 3 or 4 days. Maybe they even make it a week of doing all of these exercises. And then they start burning out on it because they're not feeling like they're getting better. And they're feeling like all of this extra bandwidth is now being ascribed to dealing with their injury. How do you thread that line of helping an athlete to take agency into their own hands and know that they are part of the solution to their problem, without also overwhelming them and say, well, you're just not working hard enough to get over this injury?
So I, as an athlete, had the same experience, and it drove me crazy that I didn't know why I was doing what I was doing, right? And so for me and for my team, the proof is in the pudding. I do not send you home with a rehab unless I have a very specific expected outcome. And if that specific outcome isn't met, there's basically a few reasons why. Number one, the person was non-compliant and they didn't do their exercises. And very frequently, my first question is, did you feel like your exercises were helping you? If they say no, that's why they didn't do them. And that's my fault, right? I can take agency as a clinician and say, I didn't do a good enough job showing you why this is important, right? Because to go back to your low back example, it's like, well, my back hurts more. And it's like, yeah, but now you can do X, Y, and Z, and X, Y, and Z are going to lead us to pain-free. And that's why for us, we have to prove to you why you're doing what you're doing. It's like, cool, we did all these tests. These were positive. We did this treatment. We retested. Everything was better. The person goes, I'm going to go home and do those exercises. I don't even need to tell them to do it, right? They just go do it because they felt the difference in real time. Now, there are some presentations that are not going to feel the difference in real time. And when it's not, I'm going to tell the person, hey, you're not going to feel any better doing this, but here's why I need you to do it. And that's where education is so important. Your provider, that's their job, is to say, hey, look, I have the answers. I'm going to give you the answers in the form of knowledge and information so that I am not your guru. I am not fixing you. I am your teammate in this, and we're going to do this together. I'm going to show you what I know, and then you're going to know what I know. There's no holding this magic secret of like, only I can do this. I think that's wildly problematic. And again, I really do believe that everyone in healthcare is there for the right reasons. And I want to note that and put that out there. But I do think that we can make mistakes as providers. And a very big mistake in my mind is not educating your patients and teaching them everything you know about a given topic, unless they tell you to shut up because they don't care. And even then, I'm probably still going to teach you something. So they have to have that autonomy to say, holy cow, I did this thing. My provider didn't even touch me and I feel better. Like that's worth more than anything on planet Earth, right? That's restored autonomy. And when you can start to restore autonomy, you add confidence. And then when you add confidence, you actually start to decrease pain because confidence releases dopamine. Autonomy releases dopamine. And so we're already feeling better, even if mechanically we still have a ways to go.
It's a beautiful way to bring it back to what we started on, which was putting the power back in the hands of the athlete by giving them a sense of autonomy and education of, okay, this is what's actually going on in my body. And this is the things that not only make it better, but this is why they make it better. And that educational piece is something that I think is a perspective shift for many people who their history with a care provider is, I'm paying you to do a service to me, not to walk through a process alongside me. Bryan, thank you so much for taking the time to educate us today, to put some autonomy back into our hands, and to go out and take back some agency in the path to healthier running. To all of those listening, I encourage you to do those exercises and to ask the questions of why does it hurt and how can I make a lasting impact away from this pain and take the power back into my own hands. It certainly has been the case for me on my own journey back towards healthy running. And by partnering with your care providers, there is a path forward out of that cycle of pain, as tough as it might seem in the moment. Bryan, thanks so much for the time today.
Yeah, of course. My pleasure.
Another huge thank you to Dr. Bryan for taking time to share with us on today's episode. Make sure to give him a follow on social media at Bryan Kent and at Forward Spine and Sport for more information on his practice. You can follow us on Facebook, Instagram, and X at Shakeout Podcast. While you're at it, don't forget to subscribe on YouTube, Spotify, or Apple Podcasts so you never miss an episode. That's it for this week. I'm your host, John Gay, saying thanks for tuning in, and we'll see you again soon for your next Shakeout.